We're all glad that you're here for today's research brown bag on evidence-based outcomes of an integrative review of the literature on blood transfusions. My name is Trissie Gwynn, and I'll have the pleasure of introducing these 8 wonderful people. So we're going to go in order of how it is listed there on the announcement for today's brown bag research. So we'll start with Emilia. If you'll just give a friendly wave. Yeah, there you go. Okay. So there's Emilia, and she graduated from Texas Tech with her BSN in 2001. She was hired at Covenant NICU and has been there for 18 years. She got her master's from LCU here in 2014, and she's currently working on the post-grad classes here at LCU. Her current role is she's a neonatal program director. She's married to Neil, and she has one son, 14-year-old Jack. Mickey, if you'll do a friendly little wave. There she is. Okay, so Mickey is a registered nurse at Covenant in the staffing department. She started her nursing career in the cardiac intensive care almost 8 years ago, and she's a member of Covenant's Research Academy for the last 18 months. Elaine in the red scarf. Yep. So Elaine is employed as a diabetes nurse specialist at Covenant, and she graduated from Methodist School of Nursing in 1985, received her bachelor's from LCU in 2003, and her master's here in 2011. She's a member of Sigma Theta Tau. Elaine presented posters internationally in Cape Town, South Africa, and Dublin, Ireland. That's where I had the pleasure of getting to know Elaine. Elaine currently chairs Nursing Policy and Procedure Council at Covenant and is active on the Research Council at Covenant and serves as a board member for Covenant School of Nursing and LCU's Nursing Alumni Association.
And I have 4 grade children.
Oh, that's the most important part, isn't it? That's the best part. Lauren? Okay. So Lauren is a resource nurse at Covenant Medical Center. She currently co-chairs Covenant Health's Research Council, and she's highly involved in many other hospital councils and initiatives. Lauren has obtained and maintained her certification of Adult Critical Care Registered Nurse. Bedside nursing and education have been her career focus, but she has taken great interest in improving care through implementation of evidence-based practice. Lauren received her Bachelor's of Science from Lubbock Christian and plans to further her education by doing her master's here as well. Or is it up in the air? Private question. Okay, yeah. To be seen. Okay.
Linnell is here, she'd be enrolled.
Right, this is true. Somebody dial Linnell. Okay. Beth. Beth received her bachelor's from Texas Tech Health Science Center. She's experienced in med-surg nursing, oncology, and palliative medicine nursing. She was the recipient of Oncology, Palliative Medicine, and Sister Maureen Van Der Zee Excellence in Nursing Awards. She is certified in hospice, palliative medicine nursing. She co-chairs Covenant Health System Research Council with Lauren. Big buddies there, evidently. Okay. And then she's traveled to 46 states and 16 countries, and she's a dog mom. That's good. Hey, Beth, just the 4 states you have not been to are?
North and South Dakota, Alaska, and Hawaii.
Are those on your plans?
At least North and South Dakota.
Okay. All righty. Mr. Randall Stennett, Dr. Stennett. 36 years of nursing experience. That includes simulation coordinator, nursing faculty of pediatrics, a nurse practitioner, pediatric cardiology, nurse manager of PI in NICU, pediatric emergency, same-day surgery, post-anesthesia care, neonatal, ICU, adult critical care, pediatrics, and general medicine. What's left?
Palliative. I have never done.
Okay. Very, very diverse. Okay, so 1981, he received his bachelor's from West Texas. 1999, a master's from West Texas A&M. And then in 2016, Randall completed his DNP from Texas Tech. He, in 2012, received certification in as a healthcare simulation educator. 2016, board certified nursing professional development. And then as I was reading his bio here, several things stood out, but one thing that I thought was incredible, in 2014 to 2016, he was the principal coordinator of a $134,000 grant for Texas Higher Education, coordinating board nursing for simulation and education. Okay. Christy. There's Christy. Yes. Okay. Christy has been a nurse for 33 years, and 32 of those years at St. Mary's of the Plains Hospital, Covenant Health. She has worked in nursing leadership most of her career, 27 years as a nurse manager, a nurse specialist, and a nurse educator. She's had the privilege of working on telemetry unit, med-surg unit. Hey, we have one you need to sign up for masters. We'll tell you. We'll tell you after. Oh, okay. Okay. I didn't mean to interrupt myself on you, Christy. Okay. She has had the privilege, she's been a tele-nurse, med-surg, skilled nursing unit, inpatient rehab unit. She's currently working as a wound care nurse educator. Christy received her master's in nursing from Texas Tech, and she's board certified in medical surgical nursing and as a nurse educator. She has 2 adopted children from China. Hope is 16 years old and Shane is 10. She stays busy with her children, school activity, sports activities, and she's an active member of her church. And then last, just because you're last on the list, that's all. Okay, alrighty. Dr. Roney is currently, okay, so there might be some tongue twisters here for me, guys, so just bear with me. So Dr. Roney currently sits on the National Quality Forum Infectious Disease Standing Committee, National Quality Forum Patient Safety Expert Panel, Sepsis Alliance Advisory Board, and is a Telluride National Patient Safety Scholar alumna. Her role at Covenant Health includes Texas Regional Sepsis Coordinator and Research Coordinator. In addition to her role in our health system, she is faculty at LCU and lead nurse planner for Texas Tech Health Science Center Continuing Education online programs. Dr. Roney is board certified in nursing professional development and possesses an adult critical care registered nurse certification. Dr. Roney's career has primarily been focused on quality and patient safety with 10 publications and 9 international presentations. She has been awarded STTI Edith Anderson Grant and STTI Iota Mu Chapter Research Seed Grant. Her research activity includes a multi-site national study on nurse engagement and quality improvement through the Improvement Science Research Network STAR 2 Plus trial, validity and reliability testing of a developed modified early warning score, the MUSE tool, the ISAR React 4 RioPro trial, septic shock urokinase trial, University of Texas Center on Aging Medicare study, and Gentech's epidemiologic study on cystic fibrosis pulmazine trial. She received her doctorate in nursing from Texas Tech, nursing practice from Texas Tech, and retired from the United States Army Reserves 23 years. Dr. Roney. Okay. You bet.
Are you gonna pass the mic down?
I should.
Is that in order?
Super, you planned ahead.
So firstly, I just want to say thank you for allowing us to participate in this activity with you guys. We're very proud of these guys. So I just want to give you a little background on the Research Academy at Covenant Health. so that you kind of know what brought all of us together, because we're a very diverse group. And you're going, how did y'all all get together? So here's how we did that. Covenant Health Research Academy is a partnership between Love Christian University and Covenant Health to help develop research skills in the nurses at the hospital. The Research Academy is a 1-year commitment at a minimum. Some of these folks have had that commitment multiple times, so I think they keep coming back. We must be doing something right. So it's a 1-year commitment, and the Academy provides an opportunity for participants to establish or advance their understanding of research through critical exploration of research language, ethics, and different research approaches. There are several goals for the Research Academy for the participants, and among those is the ability to work through the process of a project, and then to disseminate that information on their findings, hence them here today. So I would just say, I think as a general rule, we are all lifelong learners, and I think that's what kind of propels us into what we do. We were in a meeting this morning, and Dr. Long had a statement, and I will paraphrase that because I think it kind of sums up where we're kind of at here. She said, through the Research Academy, the graduates, if you will, are positioning themselves to truly impact patient care and patient outcomes at the bedside through the use of evidence-based practice. And I think that's the emphasis that we need to put on all of this. So I'm going to turn this over to them and let them share their information with you.
Okay. The reason we wanted to look at blood product transfusion detection of reaction was because over 20 million blood products transfused during 2011 had a 0.24% adverse reaction. In the literature that we reviewed, rates ranged from 0.14% to 2.1%. The purpose of this research was to ensure Covenant's blood administration policy followed current evidence-based practice when detecting adverse blood product transfusion reaction. So we asked the clinical question, in adults receiving a blood transfusion, what frequency of vital signs used to monitor for a reaction during blood product administration? So with that question guiding our research, we knew it was a significant topic at Covenant because in 2017, we recorded a 0.422% adverse transfusion reaction. This topic is important because blood transfusions have severe complications, including death. Also, adverse reactions can occur immediately or within hours post-transfusion.
So what we did a integrated research review, and we used the databases of CINAHL, Cochrane, Medline, and PubMed. The key search terms we used were blood transfusion and vital signs. And we limited it to peer review articles that were not limited to English. We actually had one that was in Portuguese that we used Google Translate for, and that was a learning experience for, I think, all of us. We wound up with a sample size of 41 articles, and after taking out the duplicates, we were left with a sample size of 29. Eventually, we ended up with 12 full text articles that we assessed for eligibility and established level of evidence on. How we did that, we did an independent review. Then we came together and did an inter-rated reliability, and that was also a learning experience because some of us rated some of the articles higher than what others did, and but even those of us that were novices, our opinion got to be heard, and so that was truly a learning experience for all of us. From that, we used 8 of the 12 articles. 4 we excluded because they weren't really relevant to the clinical question. They were more concerning a predictive view and not the actual, and the process transfusion.
Thank you. So what we found to answer our clinical question of how frequently vital signs should be monitored to detect adverse reactions during blood transfusions is that it was hard to find an answer. And there was not a clear answer because we really couldn't do any meta-analysis. There were inconsistencies found in the frequency of vital sign components or in the frequency of vital sign monitoring and in vital sign components. And respiratory rate was not always included in the definition of vital signs to identify a transfusion reaction, including Joint Commission standards. So this table here, as you see, this is a table of the literature findings and what each article defined as what they considered vital signs. As you can see in the Battered Mendez article, they didn't even specify what they were calling vital signs, but they did specify their physical assessment included chills, pain, nausea, and reports of feeling unwell, none of which would be detected with vital signs. In the Cortez-Gahn article, they only used systolic blood pressure and not diastolic blood pressure. They used heart rate but did not include respiratory rate. They used temperature, but they did not include pulse oximetry. And they did include physical assessment findings of hives, itching, chills, flushing, nausea, pain, and cyanosis, none of which, though, would be detected with vital signs alone. The DeYoung-Sullivan article was a literature review, and it looked at 10 separate articles. This is where we found those Joint Commission standards as one of the recommendations that they reviewed. And of these 10 articles, 6 of them did not specify whether or not they included blood pressure when looking for an adverse reaction. 4 of the articles did, but notably, only 1 article included respiratory rate, and 1 article said to only include it if a change was noted. But how would one note if a change was noted if they weren't already monitoring? All right, the McKinsey article we looked at included blood pressure and heart rate, but it did not include respiratory rate and temperature. It included pulse oximetry, but it did not include physical assessment findings. So when we looked at adverse reaction rate for each of the articles, it was difficult to compare since the articles didn't include the same components of vital signs used to detect adverse reactions, which could skew results. When we look specifically at the question of how frequently vital signs should be monitored, our findings primarily showed the initiation of the transfusion, 15 minutes after, and at the completion. One VA hospital study reported blood transfusion was not associated with significant changes in recipient vital signs. Notably, though, that same hospital did not include looking at respiratory rate or SaO2. So it's hard to know that if a transfusion reaction rate would have been, to know what the reaction rate would have been if they would have included those pieces of SpO2 and respiratory rate. And also notable to that was the size of the sample study. It was 3,496 blood components. And with that, that's a lot of transfusions that we might not have known if there was a reaction based on those pieces not being involved, especially considering that some of the major transfusion reactions are taco and trolley, which are respiratory focused. All right, so a lack of derangement definitions to identify abnormal vital sign components or indicate transfusion reactions prevent triggering blood reaction recognition and intervention by nurses. We have to know what is abnormal, and we have to know what changes in vital signs are enough for us to call it a transfusion reaction. what is the heart rate, the temperature, or the blood pressure changes that are significant enough for us to call it a transfusion reaction. This information would definitely affect how a nurse would report a blood product transfusion reaction. There is a paucity of evidence that exists to guide us in how frequently vital signs should be monitored and what components should be included in vital signs to identify a transfusion reaction. But throughout the literature, vital signs were noted to not be enough to detect transfusion reactions.
So in conclusion, due to the lack of high-level evidence and guidelines in peer-reviewed literature, to tell nurses how often to do vital signs or even what components needed to be included in the vital signs, whether you did all the vital signs or you just did blood pressure and temperature, to identify transfusion reactions. There wasn't the information to tell them that. An answer to the clinical question was not found. But we do know that more research needs to be completed to answer how often vital signs should be done to detect the blood transfusion reactions. And we do know that we think early detection potentially prevents adverse reactions or adverse outcomes, increased lengths of stay, higher cost to treat, and promotes customer satisfaction. So, and we just often don't even know what to tell patients. We don't include all the education we need and stuff because there's not enough evidence out there to guide us entirely on this. But some of the implications for practice that we did find in the literature is that although the question was not answered, we found that Covenant Health may not be applying the best standard of practice for detecting blood product diffusions related to reactions. And we compared our findings to our current blood administration policies at Covenant, policy and procedures at Covenant, and there were several different policies and procedures that we looked at, and we also are part of a region that Covenant Health, the Covenant Children's Hospital, the Long-Term Acute Care, Covenant Specialty Hospital, Covenant Plainview, and Covenant Levelland that are in our region. So we were also looking to standardize the policy for them, but we did make some recommendations for change in the practice and in our policy based on what we learned in the literature that we did have. And the most important, or the one that stood out to us most as a group, was that an assessment needed to be done every time there were vital signs done. And that was the best practice that we saw in our literature. And we did also make several suggestions for changes in our electronic health record. We talked with CIS team, and those changes have been made, and that will help align Covenant with the literature.
Okay, I'm going to talk briefly about policy changes. When we went through this, actually Dr. Roney took the current policy, which is a 16-page policy in our manual, and it's just overwhelming, the information in that policy. And so she took the findings and rewrote the policy basically down to 9 pages, and did a wonderful job of doing that. So what we did is we originally had 3 different policies, one on administration, one on the match identification system, which is no longer we're no longer using that, so that was removed. And then our blood component reaction policy. So all these separate policies. So we decided that the best thing to do would be to combine those and down to one policy. So that has really helped when the nurse goes to search for a policy. And what we wanted to do was we believe that vital signs need to be more specific in describing who can document and take vital signs. Part of the policy, the old policy, talked about non-licensed people taking blood pressures and writing it on a piece of paper and handing that to the RN, let the RN put that into the medical record. And so we said we do not want unlicensed people taking blood pressures on our patients getting transfusions. We also want to define parameters of vital signs and what is considered out of the normal range for looking at and suggesting that there may be a transfusion-related reaction. We also added a reaction grid from a subscription that we subscribe to called Cranes. I don't know if y'all are familiar with that or not, but that will replace a transfusion reaction policy. And so it's a table that you see here on the screen. It's very clear on what the reaction is, what timing to expect specific reactions, and what symptoms a nurse would find per each reaction type. I will tell you that we met yesterday, Dr. Roney and I, with our colleagues from lab, and that meeting went very well. They more or less, I think it was assumed that someone from lab was the expert when it came to blood administration, but we were able to go, and they had their medical director there and talk about why we were doing this and what we wanted to achieve. And they were all for, they said this was, they needed to update the policy. It was very overwhelming, and they were glad that this was taken on. And but they did want to make a few changes to this table, which would align more with what CDC, the verbiage from CDC. So that's fine. It's a work in progress, and so we're all coming together to work on this. We also added an algorithm, which I think makes it very easy for the nurse to see, what helps the nurse walk through what to do if they see a reaction and what they should be expected as far as interventions. It will help nurses walk through the process and guide supportive care. And lab also had some suggestions that they wanted to add a few things to this as well. So we're very amenable to that. The electronic health record change you see on the screen. The only change that the medical director wanted to add was to number 5. She felt like if we, that told the provider that they could either resume it or stop it if there was a reaction, and so she wanted some things modified to that. So we will make those changes.
And the assessment that's done with every set of vital signs isn't a full head-to-toe assessment, it's this specific assessment. So we're not asking the nurses to put that much extra time into that step there.
Right. One thing that we found that has been already discussed in the literature is that we could not find anything specific on how often vital signs should be done. And so the consensus was pre, and then within 15 minutes, and then after the infusion completes. But the discussion yesterday, the lab director felt very strongly that we not remove, or at least we let nursing leadership decide what needs to be done about checking or actually getting vital signs done hourly as we're doing currently. They feel like.
Her exact words were she supported us, but she said what we say as nurses all the time. I had to really look at that because it's what we've always done. But she went to the guidelines, and her own guidelines, and she's a pathologist, they said to do what we found in the literature. So she's perfectly fine with us changing that, but she had the same difficulty that we do as nurses in challenging our own practices and challenging what we've always done. So I don't know that she was against it. She just said she struggled with it like we do sometimes.
Well, and she didn't want the final decision on her back.
She wanted us to vet it through nursing
Yeah.
one more time.
Yeah. So it will go before the directors and other leadership to make that decision, even though we've We vetted it through all the other councils in the hospital, so we'll see what happens. We did add a checkbox to the checklist that the nurses can complete, which reads patient education provided, and so that comes from our CRANES education, and so it says the very same thing as what we've got listed in the couple of slides previous. And so it does give patients and families information about what they need to watch for also after the blood administration has completed.
So really, I think a lot of our biggest takeaways from this is a lot of what you see up there. But I think for us in general, as a group, it was just the process of going to the literature and really finding what the evidence said, what was EBP. And I think as direct care nurses and as an organization, I think sometimes in general, that might be a little bit scary because maybe we don't know how, or we are worried that maybe we're not looking in the right places. And then sometimes even just fear of, well, how is this going to affect me? How are these changes going to affect me personally? How is it going to affect the organization? But I think what we have found is just that it allows for more creativity and innovation, and it allows you as the direct care nurse to ask those questions. Why are we doing these things? And it allows you to review the process, because in our case, we reviewed the process and the policy, and it said some really things that we weren't in alignment with. And so you get to ask those questions, review the practices, and then implement those changes. And sometimes what's difficult, though, is that change can take a while, as we're seeing, and if you have to have patience because it has to go through committees and then another committee and then a different committee, and everyone has to have their voice. But that's a good thing, because then we're all on the same page and we can disseminate that information. And then when that change happens, then it's a really proud moment, and then we can be the leaders to implement those changes, to model that we value EBP, and that is not just part of who we are as individual nurse leaders, but who we are as an organization, that this is who we are and this is how we want to practice. And so that if it becomes part of our culture, part of our makeup or DNA or whatever you want to call it, then it kind of sets that expectation. And so then we can make those changes. And the bottom line is to improve outcomes for our patients. And I know everyone works in their own specific units, and we're all so passionate about our patients. And that is why we're there, is to make their outcomes as good as they can be. And so I think that for us was our biggest takeaway, because we learned so much just through the process of just the literature search itself, inter-rater reliability, those things, and now the dissemination of the information and waiting on those changes to happen. And so it's awesome, and it's super great, and especially because then you become the leaders and you can model that and share that excitement, and then so hopefully that will sustain the culture within our organization.
I hope everybody wishes they had my coworkers, because I have the best coworkers ever. But I have the best old coworkers ever too, Vern. I want to take it back to kind of where Randall started it off. We would not be on this journey had it not been for Dr. Long and Dr. Ford and Dr. Harrison and Dr. Ashcraft at Texas Tech. And They really had a vision to move at least University Medical Center and Covenant Health towards evidence-based practice collaboratively. It just so happened at the time they did that, Dr. Stennett and I were getting our doctorates, and so sweet Dr. Long recruited me to be her sidekick, and Dr. Alice Ashcraft recruited Randall to be her sidekick in this Research Academy journey. With that being said, Vern, Randall, and I have been in this with our colleagues since the day one of Research Academy, and this is going on our 5th year. In fact, when we finally split it off between UMC and Covenant, just because we had different needs to meet of our staff, Vern kept coming with us. See, you should have stuck out one more year with us, Vern. So I had to smile really big when I saw Vern walk in the door, because he is truly a wonderful leader as well, and I'm proud to call him my colleague too. So I hope you can see what collaborative effort can do. We lit fires in these guys, and some of us, like Beth and Christy, have been out of school for over 20 years. So yes, they have advanced degrees in nursing, but they haven't been in an academic setting for years. We have Lauren, I don't want to talk about you and Mickey too, but Lauren and Mickey haven't gone back to graduate school yet. They're bachelor's prepared nurses, and this was a new experience for them. They learned how to synthesize information for the first time, and to put the dots together and to figure out, what does this really mean for me as a nurse, and how do I really make a difference in the world and in the workplace? And so it was so many new experiences for them, especially this group here, because of either being out of school for a long time or just not having gone back to school for a long time. What is impressive is that we decided we would take it as far as they wanted to take it. Whatever their goals are, that's how far we go. And their goals were to publish, and their goals were to present. And so this group wrote their very first abstract ever, and that was a learning experience for some. It was fun. So we wrote an abstract, and they got to present nationally at the Providence St. Joseph Health Research Symposium to our peers within our organization, which is the 3rd largest healthcare organization in the United States. And not only that, we decided, let's go for it and go for International Research Congress. And so for the first time ever, a group from Lubbock is actually going to do a symposium at Research Congress. Dr. Long, Dr. Harrison, myself, Dr. Stennett, we're going to do a first abstract, or our first talk will be about Research Academy, why we did it, what results we've gotten from it. But the second abstract, or the second talk of our symposium, we have 75 minutes in Calgary, 8 o'clock on a Sunday morning, will be these guys doing what they just did with you guys and walking our audience through the integrated research review that we did. And then our final abstract that was accepted, and the final end of our hour-long, or our symposium, will be talking about the steps it took to change practice. And I challenge everyone, if you look for the answer, I know that we hear we're not done till we disseminate. I don't think we're done till we change our practice. Dissemination is a way to change practice, but you've got to change the practice where you sit. And so a lot of times when I see posters for Nurses Week, I'm like, so don't change topics next year. You found the answer in the literature, you did the work. Now, go to your policies. And I think these guys have really gotten to see from our perspective what we go through as nurse leaders, because they're nurse leaders too, but at a different level, what it takes to change an organization and move it forward. And they've got to sit down with our leaders in policy like Elaine, with our nurse leaders. They had to present this to their peers at Staff Nurse Professional Practice Council, and staff nurses had to say yay or nay. We were putting ourselves out there because they could have said, no, we don't want y'all to make those changes. And their peers overwhelmingly supported them in their work. And so it's just truly been amazing and a blessing to, actually, I have to go back before them, but they have continued on in Research Academy. But it's just been a blessed experience from, I think, day one with Randall, Vern, and I, and our LCU friends. And I feel like everybody that starts that journey with us are like Vern, they don't stop. We've got, I call them repeat offenders. Elaine is the only one that bowed out because she's just very busy, and but she had come to the first 4 years, and she's like, okay, this year I'm going to take a little bit of a break. But generally speaking, if you get stuck with us, we make it fun enough. You keep coming and hanging out with Dr. Long. Taught us some things today with Paula Ganaway. Dr. Ford has taught us a thing or two. Linnell always teaches us, and when she's not teaching us, she's recruiting us into school or something. But so I don't know. Do y'all have questions for us in this last 15 minutes? Or I don't even know if Dr. Harrison and or Dr. Ford want to say anything, because really this is all of our work collectively.
Randall, what you want to say?
I was just going to say, this is, to me, a great example of two things. How do you refute? We've always done it the way we've always done it. And this is how you do that. You prove what you've been doing forever is not necessarily the best thing. So I think that's a tribute to what these guys did with looking in the literature to say, we really aren't doing the best for our patients. The other one is I think, you can steer me right or wrong, but changing policy is a big deal. Yeah. So the point I want to make is, and I kind of alluded to that when we first started, this process from bedside nurses is going to get you more buy-in with a policy change with the other bedside nurses versus how many policies have you seen come from above and everybody resents it because you're just telling me what to do. You guys have forged a way through that policy process where I think you're going to see adoption will be better. I just honestly think if it comes from my peers, I'm more likely to listen to that than what comes raining down on my head. Those are a couple of my takeaways from this, and if nothing else, if you didn't change a policy, you probably change some of your attitudes towards research, I hope. And that's, I think, one of the big pieces too is we can't be afraid of it. We got to embrace it and move on because it's going to overwhelm us if we don't. So if you guys have questions.
I just want to say one thing. Just for YouTube for you. You know, Dr. Bernadette Melnick came and was our distinguished speaker, and she also was co-author with Dr. Ellen Fineout Overholt. They're very much proponents and encouragers of evidence-based practice, and they say to create and promote a culture of inquisitiveness. And I think that's what you're talking about with these bedside people that are in bedside care, promoting a culture of inquisitiveness as opposed to it coming from the top down. And you even alluded to that in your presentation of promoting this kind of culture and being an example for that type of culture. So that is a wonderful thing to see. The other thing I wanted to ask, what was probably your highest level of evidence article that you had? Was it a 3 or a 4? What did y'all find? A 4? So I have many, Dr. Long and I have many of our research students here in this presentation today, and they have just completed their lit log. So now they're moving to do exactly what you did to appraise their articles. By what level of evidence are they? So they can identify with exactly what you have done. And what you can say is, okay, look, they have level 4 evidence, and look what they were able to do with that. They answered questions, and what I was thinking is, you guys are now ready in the event that we did have a severe transfusion reaction. The policy is there that will save lives. I believe that because of the work that you did. So it was a wonderful, they have to do the Prisma flow diagram just like you had on your slide. So I'm so glad that they were here, that they got to see you do the step-by-step process and what your outcomes were, because they're living it right now in their semester. So way to go. recording.
Oh, I'm sorry.
I'm glad Dr. Ford was able to say that because that was going to be my question. Because I was like, oh, wow, because I just finished my literature review too, my lit log, and have noticed that, I also didn't find the answers that I was looking for. And so my question to you was, what, if any, interventions did you change from the literature that you did look at? Because you didn't get the answer you were searching for, and y'all were gonna make the changes to the policy and all that, but a couple of examples of things that you did find that you could pull from there that you did change? I was just curious.
I'm excited, let me tell you. So I think probably the biggest thing we took away was the assessment piece. In all of our looking, in all the synthesis that we did, which was in itself a journey, learning how to truly synthesize, I think the biggest thing was the assessment piece, because it was very clear in the literature that one thing that we weren't necessarily, we may have been passively doing it, but weren't specifically looking at was a physical assessment, because that'll catch a lot of the things that that will show up as a reaction. The hives aren't necessarily going to show up in your vital signs, but that is a physical reaction of a transfusion. That could be something that's seen. So I think that was probably the biggest piece for us. Did y'all have anything else, or?
While you have that, Lauren, talk about that grid. How many of y'all, I don't know how to even ask the question. Maybe I just should let you talk about the research grid. Because how many of y'all did you do the grid because it was part of the assignment for Dr. Long and Dr. Ford? I want you to hear them how I heard somebody for the first time say they appreciate the grid. So talk about how you feel about that grid and how that works for you now.
Yeah, definitely. I did not like the grid at first. I was like, oh my, this is just a bunch of work. Oh goodness. I'll do it though. But when it really came down to it, when it came down to the actual synthesis of the literature, that grid helped tremendously. And it really helped keep us focused on what was important and what information we could pull from the articles to synthesize. So.
We didn't tell her to say that.
It was music to my ears today. She goes, so appreciate a grid. And I'm like, oh, I've never heard that before.
Definitely.
I was like, yes, I won a battle.
Sorry.
Another thing that I can think of right off the top is that the previous policy didn't talk about engaging family education, family and patient family, and so that was a huge part that most of the literature talked about engaging your family at the bedside and letting them know what to expect, because many times the reactions don't occur for hours later, and so patients are able to pick up on these things far faster. And not only that, but also the SaO2, the pulse ox, and the respirations, because we really don't look at those things, and so those things were added to the assessment. So I think we added a lot of value into our assessment and being able to catch these reactions far sooner, to help our patients keep from dying from a transfusion reaction. Absolutely.
Pass it down to Beth or Mickey. I'm facilitating questions now. So Beth is a charge nurse on the night shift. And I just want to know how any of these new skills that you've learned or this experience, do you feel like it's impacting the care you deliver on a night shift and at the bedside as a charge nurse?
I think, first of all, being a charge nurse with a few years of experience, and we do get new nurses who just are always inquisitive, and it helps that fire say, okay, this is, if you want to find an answer, this is how you can do it. I now have that skill, or at least starting to get that skill of pointing them in that direction so they can become lifelong learners like myself. The assessment thing was kind of new, because I have seen a few blood reactions and not necessarily been the time that you take the vital signs. It's not going to happen. No, it's 1 hour afterwards exactly. You know, it could be 75 minutes later, and that reaction of hives or difficulty breathing may happen, and that's not necessarily that temperature thing that you're looking for in the first 5 minutes or the first 15 minutes that you would be looking for. So there was various things that I learned, and that as a charge nurse I can go and help instruct my nurses that work with me.
Same question.
Y'all have any questions for her? I just thought it amazing. I just am so proud of y'all. What did you learn? What did you take away that changes the way you practice nursing? She delivers direct patient care at the bedside on the night shift.
Yes. Well, through this whole, I learned, yeah. Well, research was something brand new to me. I actually just kind of joined the academy, not even knowing what I was getting into. So just the entire process of starting with the question and how to look for it, I actually didn't even realize that we had that, we had it at Covenant where it was available, that I could just look up information if I had a question, and we kind of went through the process on how to. So now I can, and I actually am more. I find myself asking more questions as far as what is the policy for that, and that's usually what I go and I look at already. Like if I don't know how to, have a question about something, I go and look at the policy, but now I'm actually like, well, is this something that's actually current? Or I actually look at the date on the policy as well, as far as like there's a date that the policy was reviewed. And so, you can see that it was reviewed back in 2013 or 2014 or whatever. And so I kind of start asking whether or not like that's the most up-to-date information. So, and I joined the Research Academy again, so we're doing this process again, and it's awesome the second time because I kind of have an idea of what I'm doing now. So.
Yes, I just want to add that if you're fearful of getting out there and sharing with other stakeholders that you're trying to convince to people, that leadership, that there needs to be a change, you need to get beyond that, because we are nurses. We are smart. We're educated. We are able to go to the literature and tell what the literature says and regurgitate that back. And I'm going to be honest, we were a little bit concerned about how the people in lab would take us, because it was nurses that wanted to make the change in the policy. And there was a person that everyone looked at as the expert. Well, she might be for the lab and the blood bank, but not the administration. So, but they were very wonderful and listened to what we had to say. It was a wonderful meeting yesterday, and so it's one of those things where you just have to say, let's just schedule the meeting, get it over with, let's talk about it, and let's move on. And that's what you have to do, and just get fear out of the way, because fear doesn't belong with us anyway. So you go on and you make a point, and that's how things get rolling. Absolutely.
One thing. I will say Dr. Bland is the pathologist that met with us, who's our medical director over the labs in Plainview and Lubbock at all of our facilities. And I want to say, I think that when we do things like this, we make nurses look good, guys. Those posters that you put up and everybody that gets to see those posters and the work you did, I think that we elevated our interprofessional colleagues about what nurses are doing, what we bring to the table, what we're doing. We gave them the background of why we were even doing this, because we wanted to, I say we weren't purposely going after your policy, by the way, but we just happened to stumble onto a question that impacts what you do too. And so I want to say thank you guys for going back to school at LCU especially, and
people like Vern and everyone in this room, because you're elevating nursing. And I think that's probably the biggest thing I enjoyed yesterday was I felt like Dr. Bland was just like us. She put her pants on like us. She had a conversation with us, and we had a mutual respect, and we could hold our own on the conversation, the stuff that we knew to talk about. And so I say thank you and congratulations on that part of our careers in practice.
Any more questions from the audience? Just two things that I'd like to add. Oh, no, you're good. The first one is to speak directly to what you were saying, Elaine. And as I was sitting here, I kept noticing number 19 on innovation competency, and that's collaborate with different disciplines. And so you as a group accomplished that. So anyway, I wanted to give a congratulations in that regard. And then secondly, as you're talking, I remember one of the presenters at Australia, and some of you that went. Anyway, her doctoral thesis, you may have met her, Emilia, was on blood transfusion, and so it might be a good resource to go back to the repository and reference her, but her whole premise was that it almost needs to be treated as a yes, an organ transplant, yes, because of the complexity of it. So anyway, that was just one thought that maybe I could pass on to you guys. And I really enjoyed what you shared. And also it takes me to pediatrics. And if this is what, if there's such a need for revision maybe in the adult policy, I think about the pediatric policy. Can anybody tell me about thoughts related to that?
She's our NICU expert. So we did, so that was presented, and we did get feedback from both the pediatric population and the neonatal population. So nurses gave feedback on that, and that is within the policy, and it's a combined policy.
Okay.
With.
Okay, very good.
Just
I
to
wonder.
clarify, our PICO, however you say it. No, I'm good. Okay, well, we did not specify an age. It was
All the literature, not just adults. So we didn't set out, there just was nothing that came up in our literature search specific to any age group other than adults. And so I think that that's important to know, because when the questions come up around children and neonates, we didn't really limit it, so we didn't exclude anything. Had we found it, we would have used it. But we also, it is a policy that does cover all age groups in our organization. So it does cover the neonate in the NICU all the way to the geriatric patient, and even that one in long-term care facility after acute care.
Anything else? Anything to add? Look how proud she is. Well, thank you all for coming, and you can grab a refreshment that's still there outside the door as you leave. And our next research program back?
Yeah, it's in April, the third Thursday in April, and it will be with Dr. Jessica Spiegelberger. Did I say that right?
Dr. Spiegelberg.
Spiegelberg, and yeah, she's going to present her her DNP work on ICU delirium, right?
Right.
And so it'll be a really nice evidence-based project of her findings there. She was one of our BSN students, and then went on and got her master's in DNP. So we love to showcase the work of frontline nurses, and it's so great for our students to see others just like them that are just 2 or 3 steps ahead. That's all. They just kept going and kept learning and growing like this esteemed group. And Jessica will be a really good role model for all of us to see what her work was in April.
Thank you.
Thank you.